But anyways, here's what we're going to talk about. Cardiac emergencies, acute MI, RV infarcts. Somebody comes in with real bad decompensated heart failure. Hypertensive emergencies, aortic dissections, and then rhythms, rapid and narrow and rapid and wide. Those are your two basic ones. ACLS protocols, and then hyperkalemia and what to do about it. So we'll first do some ACS. I know you guys have had this talk probably a million times, at least I know I've given it before. But acute coronary syndrome breaks down into non-STEMI and STEMI. The one that's a cardiac emergency is a STEMI. You have ST elevations. Their troponin will go up. It may not be up right now, but it'll go up. It's a complete occlusion of the lumen of the artery, whereas with the non-STEMI, it's not a full occlusion. What the answer to this one is, you got to open up the artery. Whether you're taking them to cath, sending them to a place that has a cath lab, or giving them thrombolytics, what you got to do is get that artery open. Time equals muscle, and you got to get it open. So, hang on, guys. So the other one is called a non-STEMI, and non-STEMIs are, they're not as emergent, but you do got to treat them correctly. And the treatment for this is medical management. And then they do got to go to the cath lab probably the next morning, or as soon as possible, to figure out what ruptured, what closed up, what needs to be opened. But it's not as emergent as this one. So here's your medical management. Both of them do need medical management. These are the drugs you give them. They obviously need oxygen, aspirin, Plavix, heparin or enoxaparin, 2B3A inhibitors, but we usually give that in the lab now because now that you would give them higher doses of Plavix up front, you don't need to give this in the ER. But some doctors will say, well, start the Integralin or start the ReaPro. You got to give them a high dose statin. Make sure they have a high hemoglobin. If their hemoglobin was 12 yesterday, now it's 4. They're going to be having an MI. Their troponins are going to be elevated. They're going to be ischemic because it's such an acute change, especially if they have significant underlying coronary artery disease to begin with. You got to give them a beta blocker, and eventually when they're discharged, they do need to end up on an ACE inhibitor. Nitroglycerin is optional. It helps with the chest pain feeling. It helps the staff feel more comfortable with the patient, and they won't bug you as much. Persistent chest pain, though, if you can't get their chest pain to go away with nitroglycerin and all this other stuff that you're doing, they need to go to the cath lab. You got to call the interventionist and say, listen, we've got this guy on a whopping dose of a nitroglycerin drip. We're talking like way over 100, 160, 180, the maximum. We've given him everything, on this list, that we can, and he still has persistent, horrible chest pain. Well, that guy has to go to the cath lab, whether it's, non-STEMI or not. The things you should not give is morphine, and I know we've talked about this a lot. It increases mortality. It increases infarct size. It's a veno and vasodilator. It dilates your arteries and veins, and it drops perfusion pressure to your heart. So it destroys heart muscle. So we got to stop doing that. When they're all done and being discharged, you got to put them on the SOB treatment. Statin, aspirin, ACE, and beta blocker, 90 to 94% reduction in mortality. If they did get a stent, they should be on Plavix as well, or one of the newer antiplatelet agents. So aspirin plus whatever other antiplatelet agents. Any questions on this? Yeah.
With the Plavix after the stent, aren't they supposed to come off of it after a year or so?
No, they should not. I mean, really, you have to keep them on it for a minimum of a year. But now newer studies are showing at least 2 years, and we usually just leave them on it indefinitely. And now it's only $5. It just became generic for Medicaid or Medicare. It's only $5. It just became generic about a month ago. So we leave them on it indefinitely unless they have to have like a procedure or surgery or something. But minimum is at least a year. If they get a drug-eluting stent and they need to have some kind of operation soon, you can get away with 4 weeks or 6 weeks. Just let it re-endothelialize and the stent get recoded.
Well, a lot of the other sites that we go to, some of the cardiologists don't want any Plavix. I mean, I asked them why, but they don't get it. They're really good at it, right?
We follow the evidence, so I don't know what to tell you.
No, there's Effient. Are there any other?
There's Effient, there's Ticagrelor, Prasugrel and Ticagrelor, the other two that you can give in acute MI. No, Effient doesn't necessarily have to be started in capital. The IV ones, even Integralin and ReaPro, you guys could start in the ER. I can't tell you how other cardiologists practice or why. Maybe their thought is, what if he has triple vessel disease and he has to go to Cabbage? Maybe we'll avoid the Plavix because they're going to ooze a lot. So that's one one philosophy. You can just put them on heparin and you could DC that.
As an example, you have a guy who comes with chest pain, the EKG is normal, and you're giving nitroglycerin for chest pain. Later on, troponin is positive and Stemi. So you would not recommend to give nitro for a guy with chest pain altogether?
No, you can give them nitro. That's not a problem. But make sure you give them the stuff that improves mortality. Nitroglycerin doesn't change mortality or improve it or make it better. It makes the patient feel a lot better. But the rest of these will actually improve mortality. You know, we have solid evidence and solid studies showing that this is what you should do first.
Under the don't give list, so morphine I understand, but the nitro it will be okay to give?
Yeah, you could give it. It's optional. It's not don't give. So if somebody has chest pain and their troponin comes back, you can give them nitro. You could put on a patch or paste, whatever you want. Put them on a drip, whatever your favorite nitro source is. Any other?
You know, I looked up that whole morphine issue, and I found one study from like 20 years ago. And my question is, are you talking about STEMI, non-STEMI, ACS?
Any ACS, the Duke registry, the Crusade registry, Duke University, they looked at all patients that came in with the word chest pain as their diagnosis, and they looked at outcomes, and they looked at, how big their infarct was, how high their troponin is, and they corrected for all of that. They found that the people that did get morphine had a 48 to 64% higher inpatient mortality as well as even after they left. So
you get the patient that has unremitted chest pain, they're on 80 mics of nitro, you're throwing everything at them. They're not a STEMI, it's 10 o'clock at night, and your cardiologist says, we'll see you in the morning. They're sitting there in excruciating 10 out of 10 pain. What do you do for them?
You gotta call an interventionalist and get them to the cath lab.
I'm not coming in tonight. What do you do for your patient? Too bad you're out of luck.
No, I mean you gotta.
Colleagues aren't going to come in.
They have to. I mean that's a medical emergency.
I've been there over 12 years. They're not. Work under pain. So what I'm saying is, I know you say everybody practices differently.
Yeah.
But you're one person in one group. There's a lot of your colleagues that, especially if the time is not convenient, they're not coming in.
Well, get them to say give them nitro. I mean, or morphine. I mean, I don't know what to tell you. That's you're basically killing heart muscle. I don't know why. The answer is they should come in. I don't know what to tell you what to do in real life, but that's what they should come in. I mean, this guy's having nonstop chest pain. That's an indication for cath, according to the guidelines. They need.
Send me that link because I Googled, I PubMed more.
Sure, I'll send you the article. I'll send you the article. Sure.
And how come it's not, how come it's not in, I never see it in any of these big published guidelines. They never really, everything's about all these fancy anticoagulants. They never spend any time talking about don't give morphine.
Yeah, it's more new. It was published in 2005, and I don't know how long it takes for stuff like that to get into the guidelines, but the ACS guidelines that we use are still like 2008, 2011, like a little bit of an update in 2011. They added a few things like prasugrel and ticagrelor. But yeah, it takes a while for stuff like that to get in there.
That much of a morbidity, mortality?
They should.
Plavix, the drug company throwing money and all of a sudden it's in the guidelines. If morphine's that much of a morbidity, mortality issue, I'm just saying it's kind of shocking that it's not.
Yeah, I don't know. I'm not sure why the guidelines haven't caught up, but they should. Do you guys have any other questions on this?
No, I just have a brief comment.
Yeah.
I vaguely remember reading in Rosen's, it doesn't say anything specifically, but it says that morphine's starting to fall out of favor. It may speak specifically to right-sided MIs, but it doesn't point to any literature specifically. It just is that there are some conflicting studies out there that say that morphine may increase mortality in chest pain, but it hasn't stopped me from giving it. If somebody has chest pain, it's really.
Well, the problem is most doctors, once they graduate, they kind of stop reading. I think that's part of the problem. They just practice the way they were taught, and they're dogmatic, and they don't change their habits.
So what would you recommend to me for somebody that has unrelated chest pain?
They need to go to the cath lab. I mean, the guidelines say
That's nice.
cath lab.
9 times out of 10 when I call a cardiologist, they're not telling me they're taking the cath lab.
Well,
Matter of fact,
call them and ask them
you gotta
call them
like
and say, what would you like me to do for this guy? He still has chest pain. I don't know. I mean, the answer shouldn't be, well, fine, give him some morphine. I mean, I know you guys are in a tough position, but fighting between the interventionist that hasn't slept all week and the guy that has chest pain right now that's not going away. But what are you going to do?
Usually in those situations, you can always, one option is there's always a director of the cath
Yeah,
lab,
call the.
and they're usually the ones who have to answer to the hospital and all that kind of stuff, so they have more
Pull.
things- well, not pull, but more over their head. If they don't answer in an appropriate manner and they fall outside of a protocol, they're the one who's going to get in trouble.
There you go.
So that's the other option. There's always a cath lab director, and they're usually
And if one interventionist is not coming in
Right.
enough, you can talk to the director
They're not
and
gonna
see
wanna-
what the story
Right.
is.
they have to keep the hospital happy and meet all the guidelines.
Sure.
Come back in a year, let us know when it's working over silver.
All right, so the next one that I think is a cardiac emergency, and the only reason why this is bad is because your mortality is so high if this is not treated correctly initially. A RV infarct, the mortality of it is still like 40-50% if they aren't treated correctly. Once they get past that third day or fourth day and they've kind of stabilized and everything is back to stable, their mortality goes back to whatever a left-sided infarct would be. And it's not that high anymore. But an RV infarct, you basically have your right ventricle, it has two basic functions. When it actually pumps, it puts blood into your lungs. When it relaxes, it sucks blood back out of your veins. So it has two functions. It's not doing either of those. So blood is pooling in your veins. Your lungs are clear because they're not filling up. The LV is still working. When it relaxes, it sucks all that blood out of your lungs. So your lungs are clear, and you're hypotensive because you don't have any cardiac output. The LV is pumping and doing real well, but there's no blood getting to it. So your cardiac output is a lot lower. So you're hypotensive. And they're very sensitive to nitro, morphine, and beta blockers. You don't want to give them any of these things for that reason. They're already hypotensive. And this is always a board question, at least for us. I'm sure it is for you guys. A patient comes in with an inferior MI, with ST elevations and 2-3 in AVF, with chest pain, blah, blah, blah. Their blood pressure is 80 or 90 systolic. They might ask you what's the next best step or what not to do or what is happening. That's what the treatment for it is. A lot of fluids. You got to increase that preload. You got to fill them up so that LV, when it pumps, it's pumping one continuous column of fluid back to the right atrium, right ventricle, lungs, left atrium, back into the LV. The way you know that you've given them enough fluid is you either hear it in their lungs or their FiO2 requirement goes up. If they're on 2 liters and they're setting 100% and then they drop to 88, then you filled up their lungs with fluid. You may need to intubate them, but treating their heart is going to be much more important than their lungs. So either if you have to intubate them, fine. If not, then not. They say that 95% of patients will require 18 liters of normal saline to get to this fully resuscitated state. I know it sounds like a lot. You don't have to do it all in the ER. They're probably on their way to the cath lab. We'll do the rest of it. And they may need to even put on pressors. You're going to have to probably do that because you can't really pump them that fast with fluids. The other thing is wipe off the nitro. The problem is the ambulance gets there and they either put them on nitro or give them sublingual nitro because you say the word chest pain, that's the first thing they do for some reason. So you got to get the nitro off of them. Or like the cath lab staff arrives and they see they're on nitro, you got to get it off. Now, I don't know if you guys do this, but have you guys ever heard somebody tell you get a right-sided EKG? All right, so you don't ever need a right-sided EKG. All the information that you need to diagnose an RV infarct is on the normal EKG. If you have ST elevations in lead 3 higher than lead 2, you have an RV infarct. You don't need any other information. It's 96% accurate. It's more accurate than a right-sided EKG. Instead of putting the V leads on this side, you'd put them this way. And if the ST elevation is going towards the right, V4, V5, V6, then you say, well, they're having an RV infarct. You don't need to actually do that. If you have a normal EKG and the leads are placed correctly, all you need is a normal EKG. You don't need to do a right-sided EKG at all. And I put Einthoven's triangle over a heart. Lead 2 is this one, lead 3 is this one. Lead 3 goes to the RV, and lead 2 is the inferior wall of the LV. So even just from an anatomical standpoint, if you remember this picture, you'll remember it. But lead 3, if the ST elevation or T elevation, if the ST elevations are similar, then look for how tall the peak of the T is. If the T peak is higher or the ST elevation is higher than 3, then it's an RV infarct until proven otherwise. And most books that you read will tell you if somebody comes in with an inferior MI and they're hypotensive, just assume it's an RV infarct, because it's usually a very proximal RCA blockage, and it's going to give you this pattern anyways. It's usually before the RV branch anyways. So make sure you treat this correctly. Don't sit there and fiddle around and waste time teaching an EKG tech how to do a right-sided EKG. Just call the cath lab, get them started on those medications, and get the ball rolling. Any questions on this? Not really an emergency, but if you treat it correctly up front, it'll save the patient's life. They'll end up living to talk about it. So any questions on that one? All right, so the next cardiac emergency is decompensated heart failure. Somebody comes in with really, really, really bad heart failure. They look like they're going to crash at any second. What can you do? First of all, how do you know if they're in heart failure? So you're in the ER. What do they usually say? Or what do they look like when they come in?
Short of breath.
They're very, very short of breath.
Bilateral edema, GVD.
Bilateral edema, pitting, right? Bilateral pitting edema. Orthopnea, all those things. Crackles, rails in their lungs. They feel like they're drowning. And then what else do they say? Or somebody, if they can't talk and intubated, what does somebody tell you? There's two things they say. They've been getting progressively more and more short of breath, and
They can't walk the block where they used to walk the block.
or progressively more and more fatigued. All right, those two words together, short of breath and fatigued. If they're getting progressively more and more fatigued and more short of breath, they have heart failure. So do you need any tests to figure out if they have heart failure? No, right? That's the one thing I'll stress. A person in the ER in heart failure, you should be able to diagnose it without a single test. You don't need a BNP. You definitely don't need an echo or a chest x-ray. You don't need anything. Sure, I mean, you can get some of these things later to confirm, or you may get a chest x-ray. But some people's chest x-rays look bad all the time. And we have lots of patients whose chest x-rays always look like they're in heart failure, and they're clear as a whistle. So make sure you use your clinical judgment. Heart failure, decompensated heart failure, is always a clinical diagnosis. You don't need anything. The echo eventually will tell us what kind of heart failure they have. Is it diastolic or systolic? How bad it is, how bad it isn't. You know, it'll guide treatment a little bit. But realistically, you don't need any tests. All right. I know, you know, you guys call people on the phone and say, hey, you know, I got this guy, his BNP is 10,000. Well, you know, a lot of people's BNP is 10,000. You know, they have bad kidneys. They're always got dialysis. Their BNP is always going to be elevated. So remember, decompensated heart failure is a clinical diagnosis. So, Dan, did you have your hand up? Were you stretching?
No, I was just saying the first question you always get when they make a physician is,
What's the BNP? All right. Well, you don't need a BNP. Tell them, why do you need a BNP? Tell them you don't trust my clinical judgment? The guy is in heart failure. What do you need a BNP for?
Can you work one shift in our ER? We get to pick the cardiologist.
Yeah, and the primary.
The thing is, I see Mo come in at 2 a.m. to do an echo at bedside.
No, Mo does the
You
right
do it,
thing,
but
and
yeah.
his group does the right thing. It's sometimes the other 60% that need to capture.
So here's your physical exam findings. That's all you really need. What happens first? Somebody's starting to decompensate, and it's not an emergency, but when they start decompensating, which one of these physical exam findings would you see first? No, dyspnea is kind of towards the end when they're filling up. You get an S3, right? It's the very first thing, and it's real subtle. And none of us, I don't think anybody, even me, I mean, when I'm listening, I don't know if I'm hearing an S3. I'm just hearing like an extra weird, you know, heart sound or beat. I don't even, you know, it's not that easy to figure out. But physical exam, the very first thing that happens is that, all right? And then eventually the rest. But realistically, you don't need any testing. So what kind of things can you do to make them feel better? Oxygen. All right, so here's something. So first of all, you got to get the fluid off somehow, some way, right? So diuretics work, especially loops like Lasix or Bumex, bumetanide. They work really, really well. If you add a little bit of metalazone, they work much, much better. It almost doubles the urine output, doubles how much sodium they pee off, doubles the amount of weight loss they lose. Yeah.
So in a patient that is diagnosed congestive heart failure on Lasix already, and they're coming in with decompensated heart failure, I've heard give them their dose of Lasix. I've heard double the Lasix. I've heard don't give them Lasix. What do you normally?
Well, if they're usually on PO, the IV version is usually twice as strong. But I would, like if they're on 20 a day, obviously that's not enough for them. If they come in and they're kind of short of breath, I kind of go by how bad do they look, how much pitting, how far up is the pitting going, how short of breath are they. I mean, starting at like 40 or 80 IV is not a problem. And giving somebody a one-time whopping dose of Lasix is not a problem. What? Age plus BUN. Sure, whatever rule you want to come up with. I mean, you just kind of get a feel for it. You see a guy who looks, got a little pitting, maybe just up to his ankles. It's not that bad. Give him 40. A guy comes in and looks like he's going to crash on the table and die. Give him 120. Anything in between. I mean, nobody dies of a whopping dose of Lasix one time. So go ahead and give them. The worse their kidney function, the worse their creatinine, the more you're going to have to give them. Because they're resistant to it and they don't make very much anyways. But adding metalazone PO, even if it's just 2.5 milligrams or 5 milligrams, makes a big difference. So if somebody's coming in like they can't breathe, they're decompensated heart failure, they're pitting anasarca, they're pitting everywhere, and they look like they're just going to fall apart, give them 120 plus like 5 or 10 even of metalazone. Get the ball started on diuresis. The other thing you can do is vasodilators, and there's a lot of them. Even thiazide diuretics are vasodilators, but IV, and make sure you're giving these things IV. You're not going to give them a PO Lasix, but ACEs come in IV, nitro obviously drips come in IV, and then morphine comes IV. And what you're doing with morphine and nitro is what? How do they help? You're increasing space, basically. You're venodilating them. Their veins are full and they're pitting and they're oozing fluid out of everywhere. You could create space. Morphine works in your pulmonary vasculature actually and opens that up, and obviously it's a venodilator as well as an arterial dilator. And nitro is more venous, but you're opening up their veins a little more, creating a little more space. It buys you time. These work almost instantly when you give them nitro and morphine. They work really, really fast. And then, the Lasix doesn't, you don't start peeing the second you get Lasix. So this takes some time to work. The higher the dose, the faster. But you're buying time with these in order to give the Lasix and metalazone and all those things time to work. Somebody had a question. Yeah.
On your slide, obviously what we do is just sit them upright. Don't have them lie flat.
Oh, sure, of course. Well, they're not going to be able to anyways if they're this bad. We're talking like somebody who's really, really bad heart failure. And then worst comes to worst, somebody said oxygen already, but you could put them on positive pressure or intubate them, whatever's necessary to get them over this hump of decompensation. So any questions on these drugs?
Well, if you get somebody in this situation and say they call you or whatever, they're going to start nitrogen, what are your doses that you're starting it at?
Well, think about it. Every sublingual nitro is 400 mics, and if you put somebody on like 10 mics, you're putting them on like placebo dose. I mean, it's homeopathic at that point. You gotta put them at like 60, 120, 160. I mean, and you'll get a feel for it. Everybody's a little different, but you can start at 20 and titrate it up. The nurse is never going to titrate it up. Tell them bump it up to 40, bump it up to 80. Put them at 120, whatever. I mean, nothing bad happens, with too much nitro. Eventually you'll get hypotensive, but at that point you just turn it off. It doesn't last very long. But you could do it that way. But yeah, 10 and 20 and then 30 is not anything, because it's such a tiny little dose. I mean, in the cath lab routinely when we're giving people, we inject it into their arteries like 200 at a time, 400 at a time. It's not really that exciting. You guys have any questions? See, no? All right, so let's say somebody doesn't pee. They have kidney failure, and they just don't make pee. They're coming in decompensated heart failure. That happens a lot, so what can you do? So you do ultrafiltration. They might not need dialysis because their electrolytes are okay, or they just had it, but you got to get fluid off of them. And one way to do that is call the dialysis people. If they are already a dialysis patient, they already have access. If not, you got to put in a Quinton or a large catheter, temporary dialysis catheter, and start ultrafiltrating them. Take off as many liters as you can. Now, the other thing we could do is inotropic agents. Their heart is not squeezing, their LV is barely pumping, but you do need to give them Lasix, and their blood pressure is already barely 90. So what do you do in that case? We see this all the time. The guy's pressure is always 82, 83, but we need to give him tons of Lasix because he's in real bad heart failure. He's gained 20 pounds. He's anosarchic all the way up, his hips. What are you going to do? So in that case, you could put him on a dobutamine drip and Lasix drip at the same time, or just bolus doses of Lasix, either one. But they definitely need to be on dobutamine, get their pressure at least over 90 or something reasonable, 100, and then put them on whatever doses of Lasix you want. And that's not unusual. But by then they're probably in the ICU and we're taking care of them anyways. So you guys probably just got to do your thing. If the patient's really tachycardic, like 120s, 140s, and you suspect they have diastolic dysfunction, or you look through their old echoes and all their EFs are normal, it's possible that they have systolic dysfunction. But if you think it's diastolic, and I don't know that there's a way you guys can tell, but you could put them on something to slow their rate down. The problem is they're not filling with diastolic. They have poor relaxation. If they're doing this, they're not filling anyways. Or if a patient comes in at a heart rate of 180 and they have normal systolic function, then they're doing this, they're not filling. So you got to slow their rate down somehow to let the heart fill. They're not producing a cardiac output because they're not filling. Any questions on this? All right, there's a pop quiz at the end. All right, so the next topic we'll talk about is hypertensive emergency. So what is it? What's the definition?
Elevated blood pressure with signs of the system.
Okay, good. So like what's your definition of elevated blood pressure? 130, 140? Something really, really high. Every book's a little different. Some use 180, some use 210, some use 200, and then the systolics are all over the place too. There's like 100, 110, 120, but something way higher than it should be. And then what's your definition of end organ damage? Kidney failure, altered mental status. I mean, that's chronic. What? Chest pain, right? CVA or a brain bleed. Retinal hemorrhages, papillary edema, pulmonary edema, all those things. Heart failure, they come in like pitting. So all of these things, if you look at them, any one of these things counts as end organ damage. They come in, their pressure is like 260 over 160, and they're just vomiting nonstop. Or they got a brain bleed, or their fingers are tingling, or they can't feel their legs anymore, whatever it is. Any one of these things counts as end organ damage, and there's lots of them. Even a headache. Some people don't count a headache, but a headache is the beginning of end organ damage. Sure, they haven't stroked out yet, or lost their vision, or going numb and tingling, but a headache or cephalgia is the beginning of end organ damage. So the lowest blood pressure I could find for a hypertensive emergency is 180 over 100. So as long if they're 180 over 100 or higher than that, you can count it as really elevated, and then look for end organ damage. The highest one I found was like 220 over 120 here. So pick whatever you consider elevated for you, and go with it. So what can you do for these people? What's the treatment? So obviously, get their blood pressure down. What's the fastest way to get it down? You got to give them something IV, because and the shorter acting the better, because you can fine tune it. You don't want them to go from 260 to like 90. Their brain is used to being perfused at a high pressure. Now you drop it to like almost no pressure whatsoever. So you got to get it down. You definitely got to get it under 200 or at least like around 180, whatever your cutoff is. You got your fast-acting vasodilators. Nitroprusside is very good. It's a vaso and venodilator. It drops your arterial pressure as well as your venal pressure. And Ricken, did you want to add something? Oh, my bad. So vasodilators, nitroprusside dilates your arteries and veins, and it drops your pressure really quickly. Nitroglycerin is just a venodilator, so it works similar to that. The problem with nitroprusside is what? Right, but have you ever seen that happen? You got to be on whopping doses. Did you say yes? Yeah? You've seen that happen? Oh, that sucks. Yeah, cyanide poisoning is not good. But you have to be on really high dose nitroprusside drip to get to that point. And I've never seen it happen, but maybe it's possible. So the other options are like morphine or hydralazine IV. You can give them like small doses here and there. Morphine in this way will reduce their anxiety. It's an anxiolytic as well as a vasodilator. You could put them on beta blocker drips, as long as their heart rate is not like 40. You could put them on beta blocker drips, esmolol, labetalol, something that's pretty short acting. The shortest one is esmolol. You turn it off, and in about 6 minutes or so, their pressure goes back to whatever you wanted it. But you could turn it on and off, lower it, raise it, high, whatever. So if they're at 220, just tell them, titrate it till their blood pressure is like 180. That sounds good. So what if you don't have an IV? The guy is too crazy, he's anxious, or he has no veins, he's dehydrated, whatever it is. Let's say you can't get an IV. So what can you give him? I know it's already up there, but what can you do? Clonidine, okay, so you can give him clonidine. It comes in pills or a patch, right? Hydralazine, you can give as a pill. You can give them sublingual nitro, just keep popping it under your tongue until their blood pressure is semi-reasonable. Which one of these works the fastest? No, actually. Clonidine works the fastest, believe it or not. But yeah, sublingual nitro will probably be second. I mean, that's what they say. But nitro. Okay, well, either one. So pick one and go with it. Not every place has the patches in the ER. But clonidine, hydralazine, or nitro. The hydralazine takes the longest out of all those to kick in. But those are all very good options. All right, do you guys have any questions about this? And even Lasix, if you want to give them like a 40 milligram dose of Lasix, who knows what they have. But 40 milligrams of Lasix, again, would pee out some sodium and some extra volume usually can't hurt. I mean, unless they have something else, they're really dehydrated or something, but every situation will be slightly different. Do you guys have any questions on this? All right. So the next one is aortic dissection, all right? And it's similar. I put it kind of next after hypertensive emergency because it's kind of the same treatment. You basically got to get their blood pressure down. If they're on any anticoagulation, you got to try to reverse it. Assuming they're on their way to surgery. We're talking about cardiac emergencies where the CV surgeons are like, all right, book a OR, I'm on my way, I'll call the staff in, whatever. So the blood pressure down thing is pretty simple. We went through the medication list. You want to put them on some of these things, get their blood pressure down to something reasonable, and then get them to the OR. So how do you reverse anticoagulation? So if they're on Coumadin, the way to immediately reverse it is FFP. If they're on aspirin, there's no way to reverse it, right? If they're on Plavix, there's no way to reverse it, right? If they're on, so how could you if they're bleeding and so let's say a guy comes in, the GI bleed guy's next. He's the next speaker. Somebody comes in with a bad GI bleed. They're on aspirin and Plavix. What do you do? Platelets, right? That's the only thing. You're blocking their platelets. You give them something. You give them platelets. So that's all really for aortic dissection. You guys know how to diagnose it. You get CTs with contrast, or you could do a bedside TE, whatever. I don't know if you guys do that, but you can call us to do that. But that's pretty much what it is. Do you guys have any questions on aortic dissection? See? No? So let's say a guy comes in with chest pain. All right? Patient comes in with chest pain. This is one of the pop quiz questions. They got an inferior ST elevations, and they got left-sided numbness. They can't move their left arm. Not chest pain radiating to the left side. They certainly have chest pain, but the chest pain it's not radiating to the left arm, but they can't move their left arm. They're like, you're like, move your arm, and they can't move it. What's happening? So they got an aortic dissection, an ascending aorta dissection, which is tearing into the RCA, right? So there's no more flow going to the RCA. That gives you your inferior MI. And it's tearing up into their right carotid, giving you the left-sided stroke, basically. Weakness, can't move, slurred speech, whatever. All right, so watch out for that one. I don't know if it's on your test, but that one, you have to treat that one correctly. They don't need to go to cath. They need to go to the surgeon. That's not something a balloon or a stent is going to fix. Don't anticoagulate them in that case. No heparin, enoxaparin, all that stuff. They need to go to surgery. So watch out for that one. They got an inferior MI, but they got weakness or paresthesias or drooling, slurred speech, stuff on the left side. All right? So that one, that's a common one.
We're just going to ask, every now and then we'll get the chest pain with a STEMI, but it goes to the back. We want to get them into CU as quickly as we can. We look at the chest X-ray, there's no wide and mediastinum.
How often do you see a wide and mediastinum on aortic dissection?
Precisely. So do you get, if there's chest pain going to the back and there's a STEMI on an EKG, I mean, I've always given the, like, clopidogrel and heparin.
It shouldn't be a problem. Do you guys you CT them as well? I don't know what your protocol says to do. No? You don't want to waste time or die? Yeah, but I mean, it's better than dying. I mean, you get some contrast-induced nephropathy. We can handle it, but you die, that's not fun. I don't know. What does your protocol say if they say the word radiating to my back?
Well,
You
they're
got.
having an inferior wall MI, STEMI on the actual EKG, they've got chest pain, then they're going to...
You guys just straight to cath. No CT, nothing. Sounds reasonable. And then if we don't find anything, we'll shoot their aorta anyways.
That's what I say a lot of times.
Yeah.
But
All
then
right.
they already have the heparin.
Yeah, but the heparin's easy to stop. And most of the ones here, they don't use Lovenox. They use heparin, turn it off, and an hour later, 2 hours later, it's gone. Any questions? Definitely a good question. All right, so this is the next part. ACLS protocols. This is pretty easy. You either have asystole or you have VFib or VTAC and no pulse. I'm talking VTAC without a pulse, like unstable, completely no cardiac output. So with asystole and PEA, the treatment is obvious. Just chest compressions and give them drugs. Just keep doing chest compressions, give them drugs, and hope you restart something. I'll tell you, these don't do so well. They rarely come back. The underlying problem, is usually a major one, and you can't really fix it. The other side actually does very well. VFib, well maybe not, VFib and VTAC actually has a pretty high survival rate in hospital. If they're in the hospital and the emergency team or the code team is activated right away, they actually survive pretty well. Same thing, chest compressions, you do got to try to defibrillate them as soon as possible. The earlier the defibrillation, the better the outcome. You do got to give them drugs again, but amiodarone is going to be like your key drug in this case. Amiodarone, 300 milligrams. Don't start with like the 150 or whatever comes in the vial. A lot of people just say, well, what's in the vial? Give them 2 of those vials. It's 300 milligrams, and nobody ever died of a whopping dose of amiodarone. All right, nothing bad happens. Amiodarone's problems happen when you've been on it for years or months. The half-life of it is like 55 days to 110 days. But just give them that whopping dose of amiodarone. It's very, very good at suppressing ventricular arrhythmias, all right? The other one that's on here is magnesium. You could do that as well. It also kind of calms down the ventricles. If they're allergic to amiodarone, which I've had one patient have listed on their chart as they're tacking away in VTAC as amiodarone allergy, you can give them lidocaine, 100 milligrams or like 1 milligram per kilo, or procainamide. But that's basically it. So people usually want to like rush to intubate somebody in a code situation. In the hospital it's fine because you have everybody here, but out in the field, somebody drops in the grocery store and you put the automated defibrillator on them and you analyze their rhythm or it analyzes it for you. You don't have to rush to intubate people or start blowing into their mouth you know, they took that out of the ACLS protocols way back in 2008. I know that sounds like not that long ago, but that's a while ago in guidelines world. But in 2008, they took out the blowing into people's mouth and doing mouth-to-mouth resuscitation. Just do chest compressions. That moves enough air in and out of their chest just from the recoil and suction. It sucks air into them. So you don't really need to sit there and do mouth-to-mouth. Now it's 100 per minute, and don't even worry about, you know, blowing any air into them. Any questions on this? Then we'll get a little bit more into, you know, basic, certain kinds of rhythms. Because, you know, you guys know what to do with this. Somebody comes in the ER with no pulse, you know, you start chest compressions and start doing this. It's not rocket science. But sometimes when they're like talking to you and they have a funny rhythm, then it's like, what do we do now? So this part is not too complicated. You guys have any questions on this? You know, just do your ACLS protocols. I had an ER doctor one time call me, and it wasn't from here. But an ER doctor called me once and said, hey, I got a guy in VTAC and he's starting to crash. What do you think I should do? I'm like, wait, are you like consulting me, or like what do you mean? They're like, well, he's in VTAC and he's starting to get hypotensive and he's going to crash. And I'm like, well, normally I would just start ACLS protocols. I'm not sure what you're asking. But it was like a new doctor. They had just started 2 days ago, and I don't know where they came from, but they came from a place where obviously they could just call the cardiology fellow and they'd be there in 2 seconds and help them. So you guys are getting a hell of an education. You guys are going to be phenomenal doctors. You're not going to be consulting the first year cardiology fellow for a VTAC, right? So what's the, any questions on this? No? All right. So here's a little bit of a trickier situation. Patient comes in and they got a fast and narrow rhythm, 220, or like, you know, something real fast, and it's narrow, it's not wide. So what are your thoughts? What? How fast? Whatever, you pick a rate. 120.
Regular, irregular?
It looks very regular. You can't see P waves, it's kind of fast. What's SVT? That's a sinus tach, atrial tach, junctional tach, AVNRT, AVRT. What else? MAT, AFib. SVT means a lot of things. Huh? AVNRT is what you mean. When people say SVT, they mean AV nodal reentrant tachycardia. 80-90% of the time, that's what it is. But what if it's, all right, so let's say you think it's AVNRT. What do? So you give them adenosine, right? You know, you did some vagal maneuvers, didn't work, gave them some adenosine. It didn't convert. It just slowed down.
If you have re-entry, are you not supposed to give adenosine, or should
We'll get to that one. So let's say you give them adenosine. Parkinson, this is your final exam, all right? Patient comes in, heart rate is 240. It looks regular. You can't tell if it's irregular or not. You give them some you try like carotid massage, make them cough, you know, whatever. Doesn't work. You give them 6, 12 of adenosine. Nothing happens. It just slows way down. Instead of being 240, it goes down to like, you know, 120 or maybe even 60. And then what do?
It is
I don't know what it is. I'm telling you now what. Pressure's okay, they're stable. What do you do now? Try amio? Why? What's your thought process? So here's how you should approach these. Yeah, what's the rhythm when it came down? So you think it's AVNRT, right? You give them something like adenosine, and it does not convert. So that's not AVNRT. Don't keep giving them adenosine or anything crazy like that. All right, so you give them adenosine, nothing happens. But now it slowed down and it looks really irregular. All right, then you think it's AFib. Or it slowed down and it just looks like sinus, you know, some kind of sinus rhythm. Then fine, maybe they were just in sinus tach. Or it slowed down and it looks, you know, like what else could it possibly be? Well, those are really the only two options. It's not going to do that. I mean, it could. It could look like that. So now what? So you don't keep shocking them at this point, right? Or you don't keep giving them adenosine or doing any of these things. So what do you do now? You just got to put them on something to slow it down, because the adenosine worked. It's an AV nodal blocking agent. It's really short-lived. It gets broken down in your RBCs, right? So it lasts like, what, 6 to 10 seconds max? So now you just put them on some kind of drip to slow them down. If it's rapid AFib, get them down to like a reasonable rate, 110, you know, 100, whatever you can. Or if it turned out to be sinus tach, figure out what's wrong with them. What can you do for somebody if you slow them down and it turns out to be sinus tach? Let's say they're tacking away at 160, give them some adenosine, and it looks like sinus tach. Then what do you do? Send them home. No, you don't want to send them home, but what does sinus tach tell you?
Underlying problem. You got a problem.
There's an underlying problem causing your heart to react correctly. Sinus tach is an appropriate reaction to something, all right? Either they exercise too hard, they lost a lot of volume, they're infected, septic, whatever it might be. There's something going on that's not explained, but the heart is reacting correctly. If they're in sinus tach, the heart is fine. It's not the heart that's the problem, all right? They have an underlying problem that you need to figure out. So then, the other question is if it's fast and narrow, is it AFib or something else? If you could tell right away that it's irregular or semi-irregular, then you know it's AFib. Is VTach ever irregular? It can be, but usually not. Usually it's very, very irregular and wide, right? So you put them on, if you know for sure that it's AFib, you could put them on, something to slow it down, a beta blocker drip of some sort or a cardizem drip, whatever you want. The problem with cardizem is what? Or diltiazem in generic terms? It's an AV nodal blocking agent, but it's a calcium channel blocker too. If they have a weak heart, you're actually making it weaker. So just make sure you don't think they're like a bad heart failure patient. So, and if they are, beta blockers would be perfect anyways. So try to pick one of those. Any questions on this? We had a guy one time, and I think I might have told you guys this once before. They called me in the middle of the night, like, hey, we got a guy who's in a fast, narrow rhythm. We gave him adenosine 3 times, nothing happened. I said, well, what happened when you gave him adenosine? They're like, well, it looked like AFib. And I'm like, okay, so like, what's the question? They're like, well, he's unstable. And I'm like, all right, so then what have you guys done? Like, what did you do? Like, well, we shocked him 3 times. They shocked this guy 3 times. That was in AFib, thinking that, I don't know, he was not being stable or whatever. And the guy's apparently talking to them. The story I got is he was actually communicating, and they would like sedate him a little and shock him. The guy didn't do so hot, for many other reasons. He had a lot of problems. But that's not how you treat, these kind of things. If you give them adenosine and it just slows down and looks like something else, it's not AVNRT. If their heart stops and then resumes rhythm at some slower rhythm that's now sinus, that was AVNRT. Yes, Noah?
What if all this fails, but they're still stable?
If all this fails and they're still stable,
Well, not stable.
send them up.
We had a weird case of Providence, and we gave all this. We initially gave
How much beta blocker?
we gave like 3 doses, IV boluses.
IV of 5s?
Yeah.
You probably got to give more.
We gave that. We gave.
Or put him on a drip and just go up.
We gave adenosine. We shocked him twice.
So then he wasn't stable.
Well, that's what I'm saying. But the point is we ended up transferring him because we were at Providence, and we ended up transferring him. We did I don't know what else we could have done. Can you use, I guess, amiodarone in these situations?
Well, what would you want the amiodarone for? Do you think it's a ventricular rhythm? Did it look wide?
No, it was 100%. It was unstable AFib. There was no question about
The key is just get it down.
But it
wouldn't come down.
We had him on cardizem drip.
You could try a little digoxin.
We did.
And what happened?
Nothing.
Some people think
Literally sent this guy with a blood pressure.
some EP doctors will tell you that digoxin doesn't do anything for
We
AFib.
transferred this guy with a blood pressure of 70 and a heart rate of 180.
That's
nothing
insane.
else. What else could we do? We shocked him 3 times.
You could just keep giving him tons and tons of low pressure.
With the blood pressure of 70?
Yeah, the pressure is 70 because he's doing this and he's not filling up. But as soon as he starts doing this, he'll get a better blood pressure. You got to slow him down, though. You guys were afraid to give it to him.
No, we gave him 3 doses.
You were worried about his blood
We
pressure.
gave him 3 boluses.
Give him higher doses. Give him 10s.
But he had a blood pressure of 70.
Yeah, because his heart's doing this.
Every time that you did it.
If your heart's doing this, you're not going to have a blood pressure.
Yeah.
So that's one issue that comes up a lot. And they've called me about, like, hey, this guy, his blood pressure is barely 80, his heart rate is 180. Well, give them an IV bolus of cardizem or low pressure, whatever, slow their heart down. Maybe this guy's, a unique case, but get their heart down so that the heart actually opens up and fills and pushes out a blood pressure.
Do you ever use or have you ever heard of push dose pressors?
Push what?
Push dose pressors like phenylephrine and stuff in the meantime Because a lot of times,
I mean, in phenylephrine, fine, but other ones you're probably just going to make his tachycardia worse. Not levofed, but like dobutamine and dopamine is just going to make it worse.
because we use that for him.
How much DIG did you give him? Because DIG will eventually stop your heart and slow it down big time if you give it at the right dose.
I think
I mean, did you give him 500 IV or just
Yeah,
like 250?
500.
500?
It was just a weird case. I mean, it ended
I mean,
up-
he probably has way
it
more
was-
other
it
issues.
was like, he had a thyroid issue, and that kind of was the underlying thing.
Well, then you got to do other stuff in that case.
No,
So,
we didn't. That after a 4 or 5 day ICU stay at Stroger, they figured it out. But
I gotcha. Well, I mean, you're always going to have something really weird. Yeah.
I have kind of similar situation where you have AV and RT, you try adenosine and it doesn't work. If the slow rate does not definitely look like AFib, you should not give beta blocker, right? Because it could be sinus tachycardia, they can be in shock. We have another question too. What if it is a narrow complex WPW? Is there any
So narrow complex WPW is usually stable. If it's not on every single EKG, they're usually stable and they'll never have a problem with it. If it's on every single EKG that they have, and yes, Ann.
I had one here that was really fast, like 220s. You couldn't tell what it was. And she was borderline.
But why was she tacking away though? Was she just in her accessory pathway going crazy? I mean, that's the question. You could give them drugs that block accessory pathways. You don't want to give them a pure AV nodal blocking agent because if you do block the AV node, which throttles their, WPW can go up to 300 beats a minute, and the AV node is the only thing throttling it. If you give them something like adenosine or a beta blocker or cardizem or something that blocks the AV node, you could get the whole heart going at 300 beats a minute, and then they're going to crash. It's almost like being a real fast VTAC.
You can't necessarily tell the EKG.
Yeah, because it's so fast. If they don't know they have it, what you can do is give them things that block their accessory nodes, like flecainide, propafenone, even amiodarone. What else? Procainamide. You can start with adenosine and see what happens, but if they go higher and it goes up, you're probably going to be shocking an unstable rhythm.
You're going to go with what,
You're going to have to.
common thing. You're going to start with this stuff, and then he gets worse. Then you're like, okay, there's something else going on. You got to treat the patient.
Then you.
Crash.
Then you're going to have to give them a whopping dose of amiodarone and maybe even shock them out of whatever unstable rhythm they go into.
Common thing.
Yeah, WPW is extremely rare. Yeah, Noah.
does amiodarone have any utility in AFib with RVR?
It's good at amiodarone. This is a good question. What does amiodarone do with AFib for RVR? It can slow it down, and people feel like it won't drop your blood pressure as much. But if somebody is tacking away at like 180, 170 to 180 irregularly, the problem with their blood pressure is that they're too fast. You got to get their heart rate down so that their heart fills so they can create a cardiac output. It's like being in diastolic dysfunction. You're not filling your heart, so you can't generate, even though it's pumping nicely, it's only filling with like 10 milliliters, and it's not really getting that nice big ejection fraction. So you got to get it down. And maybe your guy was, something else was going on, but generally get their heart rate down to like 110, 120 or something more reasonable. Their pressure will come up, or give them fluids. A lot of times these people, decompensate into real fast AFib because they're dehydrated or, lost volume or infected and septic, whatever it might be. All right? Any other questions? Cool. Any questions? No. All right. So the next question is if they come in fast and wide. So fast and wide, it could be one of two things. It could be either VTAC or one of the SVTs, which is even sinus TAC, anything supraventricular, not ventricular. Remember, ventricular is VTAC. Supra is anything else that gives you usually a narrow rhythm. But if it's wide and fast, it could be SVT with aberrant conduction, meaning a left bundle branch block or a right bundle branch block. So if you have a left bundle branch block, you're going to look wide, all right, regardless of how slow or fast you're going. So they come in fast and wide, you got to be thinking either VTAC or one of their normal supraventricular rhythms, but with a left or right bundle branch block. All right. So what do? So VTAC is pretty simple, and we're assuming these are not crashing people. We're not doing ACLS protocols. So VTAC that's not crashing, any one of these drugs works. Most people use amiodarone because it's really common and they understand the dosing, and it works really, really well. So amiodarone would be a good drug. You can give them, if they're not crashing, you could just give them the 150 bolus and then put them on a drip, and that shouldn't be an issue. So that's pretty much all there is. You could use procainamide as well. If they're allergic to any of these things or whatever, if you like lidocaine, use lidocaine, doesn't really matter. SVT with aberrant conduction, it could be AFib with the left bundle branch block that's really fast, like it's 110 or 120, whatever, and it looks like VTAC to you. So you could use the usual stuff that you slow down a normal, a supraventricular heart rate with, beta blockers, calcium channel blockers, whatever. Just get it down and you'll see. You can always, if somebody's in VTAC and you give them a beta blocker, nothing bad happens. But if it starts slowing down, you might think it's something else, not really VTAC, right? If you give an AFib that's going so fast that it looks regular, you give them a beta blocker and it slows down, and now you can see how like irregular and erratic it is, then it's not likely VTAC. VTAC can be irregular, but it's really, really rare. Most of the time it's very, very irregular. Any questions on these? You raising your hand or stretching?
Raising my hand.
Go for it.
So, if you're not sure, do you go down VTAC route and give me amio?
If you're not sure, amiodarone will even slow this down a little. It could at at a nice enough dose. So you could do either. But if it's VTAC and you give them amiodarone, it's not only it'll slow it down and it may even convert it. So it really kind of depends. Now if they're one of these people that has resistant VTAC, and it's not going to convert, no matter what you do, nothing's going to happen. Nothing's going to change. They need to go get ablated. VTAC that's stable and sustained and not changing is usually somebody who has had coronary artery disease, had an infarct, and their LV or RV is scarred, and this scar is giving off its own electrical signals causing the heart to fire. So the only treatment for resistant VTAC is going to be ablating them in the cath lab. It's a procedure. No matter what you do, it's not going to change anything. As long as they're stable. If they start crashing, then you got to do what you got to do. And that would go back to ACLS protocols. But for this, we had a guy in the ICU once in VTAC for like 3 days straight, and who knows how long he had it before he decided to come in. So it just depends. If they start crashing, sure, give them a big dose of amio and shock them. But if not, you can just wait it out. You don't have to do anything. If a guy comes in and his heart rate is 80, it's like a slow VTAC, and he's just hanging out and he's talking to you and doing whatever, you don't have to do anything. Now you call the cardiologist, they might say start an amio drip, just to help load him up with amio before we take him down and try to shock it or whatever, or ablate it. But you don't have to do very much. You just keep an eye on him, send him up to the ICU or whatever. Any questions on that? All right, so the next cardiac emergency, and you might not think it's a cardiac emergency, but it can be, is hyperkalemia. So normally, what they tell you to find on an EKG in hyperkalemia is like these tall, narrow, sharp peak T waves. That's true on real low levels of hyperkalemia, like 5 to about 6 something. That's what you're going to see. But as the potassium gets higher and higher and higher, all that gets blunted. Your QRSs get wide, your P waves come down, your T waves come down, your T waves are more curvy, your QT interval prolongs, and then your S wave kind of gets dragged out. You'll see the S waves, you got your R halfway through the R coming down, or like as you're going to the S, it gets kind of pulled out almost. So these are very, like this, nothing else gives you this on an EKG. As soon as they do an EKG in 10 seconds, it takes 10 seconds to do one, as soon as they whip off an EKG, you can diagnose the patient with hyperkalemia. No other pattern, nothing else in the world gives you this kind of pattern on an EKG. And of course, as you get higher and higher and higher, you start getting that, sine wave and wider prolonged QT. The one thing I'll tell you is not everybody's potassium is the same. Like for me, if I had a potassium of 5.8, my potassium is never that high, I may start showing some of these. All right, so it's not the same. So every single person, you know, these dialysis patients come in with potassiums of 7 or 6. They might not show any of those findings because they're just used to it. Their body is well adjusted and whatever. But if they do have any of these findings on an EKG, their potassium is too high for them. All right, so make sure, you know, that you treat them all the same, even if it's just 6, 6.2. Don't sit there and wait on it. You know, especially if they're giving you no P waves, real wide QRS. Real bradycardic, you know, this potassium is dangerous for this person. It's way too high for them. And I'll show you a couple EKGs of that later on. So what's the treatment? You know, you guys know all this. The fastest way to get somebody's potassium down is what? Insulin. So you got to give them insulin, and you got to give them sugar as well because it's going to drop their sugar. What's the calcium gluconate for? It stabilizes cell membranes, but what else does it do? It helps the potassium get across. You're trying to push the potassium into cells, and the calcium gluconate helps with the transport of that. Also, you know, if it's that high, you should be, you know, in the process, give them on insulin, give them the D50, calcium, but you should also be in the process of dialyzing them. All right, start putting in a big catheter. You'll save their life. You'll notice within the first 20 minutes their QRS gets to being narrow again, their heart rate comes up, the T waves go back to normal, and the P waves come back. So if they're that high, make sure you do this. So what else do they tell you to give? You're raising your hand. What?
Before we get off of calcium gluconate, we had somebody had an interesting case like last week or so. Somebody had DIG and then they eventually got a lot of calcium for their potassium that was elevated. Do you often see stone heart or anything like that?
Do you see what?
It's like stone heart or cold heart where the heart basically stops after you give them calcium and they're on DIG or a high level of DIG?
That's a good question. I've never seen that. The problem with DIG is if their potassium is low and they're on DIG, it almost potentiates the effects of DIG. But I don't know, I've never seen that coming. I mean, DIG is a really bad drug to use. People should not be on DIG for AFib. The only indication for DIG now is what? Systolic heart failure. And even then, it doesn't improve mortality and morbidity, but it keeps them out of the hospital and it keeps them symptom free. So, you know, you could kind of look at that as maybe a morbidity. But, you know, no one should be on DIG for AFib. But I've never actually, you know, had that experience. Yeah.
No, we used to always just kind of throw the albuterol treatment in there with part of it.
I mean, it helps a little.
Now it's saying it's
It's not as good. And then has anybody told you to give them bicarb? So how does bicarb, how much potassium reduction do you get with bicarb? Huh? Well, the reason their potassium is going to be elevated is it's compensating for the acidosis. DKA is a different story. You give them fluids, that goes away. But how many times do they tell you a guy comes in with potassium of like 7, they say give him bicarb? How much does bicarb lower your potassium by? Between 0.1 and 0.8 in all the tests that they've done. So that's not even very much. And how long does it take to actually work? 6 hours. So if you give them bicarb in this acute setting, you're saying in 6 hours I want to reduce their potassium by like 0.4, 0.5 maximum. So it's not very good. This is the fastest and easiest way to get their potassium down. And if it's that high where they're getting the real wide, you know, bradycardic EKG changes, the stuff down in this area, you definitely need to start dialysis. All this stuff is temporizing because the potassium is going to come back out of their cells and it's still going to be high. So you got to get them on dialysis and start sucking that stuff out of there. Any questions? So bicarb and albuterol, you know, it's fun and maybe it's exciting to do and you see their heart rate go up, which is probably not so good. But definitely give them this stuff. These are my 2 kids. So now we'll do the pop quiz, all right? Well, this is how you can find me. If you're not my friend on Facebook, I'm deeply offended, all right? So patient comes in, says, I think my heart's racing. You see this EKG, what do you want to do? What is your thought process? Not the older generation, the new ER guys. Slow it down, right? So what could you do? You could try beta blockers. We give them how much? What do you want to give them? So it's fast and narrow, right? First thing God decides if wide or narrow. It's narrow and it's fast. So fast and narrow. What do you want to give them? Somebody said adenosine, but somebody said slow it down. What do you want to pick? You want to try to convert it or slow it down? Somebody's saying slow it down. So what do you want to give? She wants to give cardizem. How much? You got to know these. 10 milligrams IV. We give it to them. Nothing happens. What do you want to do now? So what's your thought? Nothing changed. It's not SVT because that could be anything. You got to pick an actual rhythm. Give some more? You could. Yes, Dina.
So I still want to give him adenosine to slow down his rhythm so I can see what the underlying rhythm is.
So you could do it that way. So her thought process is maybe it's AVNRT. So don't use the word SVT, all right? Because SVT could be anything. Anything that's not VFib and not VTAC is SVT, all right? So pick a real rhythm. So you're thinking AVNRT, right? So you give them adenosine. What on this leads you to believe it's AVNRT?
So he's tachycardic.
They're tachycardic, certainly. They're going about 160, 170.
From here, and maybe it's because I'm so far back, like it's hard for me to appreciate if there are P waves.
It's hard to tell because it's so fast.
The rhythm looks regular to me. It doesn't look irregular.
Sure.
So my thinking is if I can not necessarily convert him with the adenosine, but slow him down just so I can see the underlying rhythm.
Both of which are good thoughts.
The underlying rhythm.
Sure. So she gives them adenosine. She gives them 6 milligrams. Nothing happens. Give them 12, right? So you give them 12, and the heart stops. Huh? That's what it's supposed to do. That is exactly what happens. It stops. So what do you got to make sure you do? Make sure they're connected to the pacer pads, right? Because you may have to pace them. What if their heart never restarts? You got to make sure they're connected to the crash cart, connected to the pacer pads, and put it on, monitor. So you give them 6, 12, whatever. Heart stops, and then it starts coming back. It comes back at 50 beats per minute, or 40, then 50, then 60. Now it's 70, and it looks sinus. All right. So what do we think it was? Sinus tach? No. AVNRT, right? So we think it was a supraventricular tachycardia called AVNRT, AV nodal reentrant tachycardia. We wiped out the AV node, heart completely stopped, eventually came back at a sinus rhythm of like a reasonable rate, all right? And usually these are like young people that know. They come in and they say, my heart's racing again, I coughed, I did slow deep breathing, I put an ice pack on my forehead, whatever, it didn't go away. Usually when I cough a few times it goes away, it didn't get better. I think my heart's still racing, yeah.
I think Parkson was first.
Parkson, go ahead.
Do you recommend, like, if they're like 30 and something, they've had this before, we get them out of the Zenicard to keep them at least for ops or decent?
No, you don't have to. You could ship them out. And what's the worst thing happen? It comes back? They know they have it, and they get it a lot. And what would you observe? I mean, I don't understand. What would you observe?
Well, you gotta make sure they don't go into it,
What happens if they do?
His question is SVT
Is it going to kill you? No.
is it something that's a precursor to something that's going to get worse later on? Is it a sign?
No. It's not. It's a sign that their AV node has an accessory pathway that sometimes comes on. If you want, well, you may not do it, but you could put them on flecainide and low pressor, 50-50. Yeah, you can't put them on flecainide by itself because this is AV nodal dependent. You got to block the AV node. Otherwise, you're blocking just the accessory pathway, and you're leaving the AV node intact, which is not good. But that's probably not something you guys are going to do. I mean, you're going to be like, here's some adenosine, go home. I mean, right? If it comes back again, they come back, or they cough it up. Whatever. Did you want to add something else?
Actually, it was the same question. Do you keep for ops, which listening to a recent lecture, the answer to that was no. And then would you tell the attending that what's to do a complete lab workup, including troponin on somebody with a known SVT?
A heart attack will never present with tachycardia, at least not fast tachycardia. They may be 105, 110, but 180 or 170, whatever this is, it's not a heart attack. There's no point in doing a cardiac workup, not even an echo or anything. I mean, it's not going to tell you anything. That can all be done outpatient. We'll echo them and figure out if they have anything, but it's still not going to answer why do they have AV-NRT. They need an EP study and maybe an ablation if it keeps coming back and it's annoying. Or they could just take the 2 pills, you know, for the rest of their lives. Any questions? All right. Now, patient comes in, says, I think my heart's racing. What do you want to do? Huh? They're awake. They're like, you know, I don't feel right. I feel like my heart's racing. I've never had this feeling before. Blood pressure is like 120. So what do you think it is? Clearly it's wide. But could it be sinus tach with a right bundle branch block? No. Right? That's not what a right bundle branch looks like, first of all. So yeah, I kind of threw you off. But yeah, but it's a possibility. You know, you don't always know. I mean, how would you know? So it could be a sinus tach, or it's not even really, is it that tacky? Yeah, it is. So sinus tach with a right or left bundle branch block. I mean, what would you do then? So this guy walks in and says, I feel like my heart's racing. What do you want to do? You give him amiodarone, right? But he's talking to you. Why do you want to give him? Why do you want to expose him to whopping doses of iodine and amiodarone and all this stuff? Should give him 150 of amiodarone. What else could you do? I mean, you could do that. It's not gonna, huh? You could give him lidocaine, sure. So how do you know this is VTAC? You know, you do. It's regular and wide, but sinus tach could do that. Use Brugada's criteria. One of the best ones, or the one that helps you distinguish the most, is what? If you look at the chest leads, V1 through V6, there's no RS complex. All right? Do you see an R and an S in any of these chest leads? You really don't. Here, I mean, I don't even know if this is the upslope or the downslope, but there's just an R, and I don't know that you can argue that that's an S. But you really don't see any RS complexes. Or you can flip over in your EKG book or Google the word Brugada criteria for VTAC and look at the shape of V6 and V1 and what shape it'll be in. Sinus tach or an SVT with aberrant conduction, and in this case a right bundle branch block, will not look like this. This one is clearly VTAC. So they're talking to you, you give them a little amiodarone, whatever, they're just having a good time. You called the cardiologist, I'll see him in the morning. Suddenly their pressure's like 70 and they're like, whoa, and they're starting to lose consciousness. They're kind of losing consciousness anyways, you don't need to sedate them. Then what do? If they're still like really with it, sure, sedate them a little and zap them, right? You got to defibrillate them. But at that point, give them the bigger dose of amio, right? Any questions on that one? So what's this? Why is it an RV infarct? How did you decide that? Right, so the ST elevation in 3 is higher than 2, 96, 97% accuracy for RV infarct. So what do you want to give them? Lots and lots of fluids. What do you got to wipe off? Wipe off the nitro, because somebody I'm sure gave them nitro. What else do you want to do? How do you know you've given them enough fluid? Let's say they're hanging out in your ER for a while. They either hear, fluid in their lungs or their oxygen requirement goes up, right? Or you need to intubate them, right? So this is an RV infarct. So do not give them anything that'll make them more hypotensive than they already are. They're very sensitive to anything that would drop their pressures even more. Any questions on this one? Do you need a right-sided EKG? No. All right, what is this? No. Good thought, though. Not Wellens. So describe what you see. It's kind of wide. It's kind of regular. Maybe there's P waves. I don't know. P waves are usually easy to find in 2, but I don't really see them. V1 is usually good for P waves. I don't really see P waves. At least they're very blunted if they're there. So what is this? It's an electrolyte abnormality. It's hyperkalemia, right? And if it's this bad on EKG, you need to be getting all that stuff, the insulin, the sugar, the calcium, and a dialysis catheter. All right, this potassium, no matter what level it is way too high for this person. all right? If it was those tall, narrow, you know, T's, that's not a big deal with potassium, but this is, all right? So watch out for this. And if you notice, and it's easier to just kind of point it out, you have your R wave goes up. As it's coming down into the S, it's as if somebody pulled the paper and made it go faster. The S gets pulled out and stretched, you know, longer than it should, as if the paper started going faster with every S wave. Nothing else does that on an EKG. This combination of findings is always hyperkalemia. You don't need a blood test. Sure, I mean, you're going to do it anyways, but in 10 seconds with an EKG, this hyperkalemia is way too high for this person, and they will die if it goes any higher or you keep them like this. So nothing else will give you this kind of pattern on an EKG. Any questions on that one? It's getting wider, the QT is getting longer, the P's are dull, the T waves have come down, the S got stretched out, the QRS is wide, all that stuff. So what is this? So describe it. Is it wide or narrow, first of all? It's fast, right? I mean, it's kind of fast. It's not super fast, but it's kind of fast. Is it wide or narrow? It's kind of in between. Is it regular or irregular? It's kind of irregular. You notice the gap between these two and these is irregular. So right away, the only thing that really gives you an irregular beat is either MAT or AFib. And if you don't see P waves, like, you know, I really don't, it's too fast really to see P waves, but it's probably AFib with the left bundle branch block or the start of a left bundle branch block. It's not totally wide yet, but it's getting there. So this is one of those ones where it's not VTAC. And the fact that there's RS complexes, you know, there's your R, there's your S, there's an R, there's an S, RS. The fact that there's RS complexes in these leads tells you it's not VTAC, but you could always pull up Brugato's criteria for VTAC to be sure. But this is AFib. You just got to do what? If they don't like it, they're telling you, I feel short of breath, I'm fatigued, I feel tired, my heart's racing. You got to slow it down, right? With what? Adenosine? No. Either a beta blocker or a calcium channel blocker, right? What is this? Quick, quick, quick. First thing comes to mind. Hyperkalemia again, right? This one, not as bad as the other one, not as high as the other one, but it's starting. Look at the S, how the S is starting to get pulled out and whatever. And you don't really, the P waves are dull or not non-congruent, or you got like a prolonged PR where you do see the P waves. There's a little bit of a P there. So this is the start of hyperkalemia. The other one was worse, all right? But this is the start of it. What is this? Huh? What is it? See, that's a good question. Why are you not doing chest compressions instead of getting an EKG, right? Why are you doing EKGs on this guy? No, but what is this? What causes this? Super high potassium, all right? This is the one where, like, what are you wasting time for? No, this is real bad. This guy's potassium was like over 10. We did eventually get the dialysis catheter in him and dialyze him, and within like 20-30 minutes everything was back to narrow and you know, not so bradycardic and back to pretty good. Any questions on that? What's this? Wide or narrow? Wide. Regular, irregular? It's irregular. So what does it make you think? AFib or VTAC? AFib most likely. VTAC can be irregular, but it's very, very rare. So this is probably AFib. You got an RS complex in there. RS. So this is AFib. So your options are what? If they're too, you know, they don't like it. Slow it down, right? Some kind of, you know, beta blocker, drip, or IV beta blockers, or whatever. What about this one? Narrow or wide? Very narrow, very fast, probably like 160, 170. So what are your options? Slow it down, right, but with what drugs? Either slow it down or convert it, right? It's kind of what it comes down to. So what are you thinking? You want to go with Dina's answer like last time? Adenosine, see what happens, and make sure they got the pacer pads on in case their heart doesn't come back. So give them adenosine, converts, you know, it was AVNRT, slows down, you'll see what it is. Right? You might see flutter waves. You know, you might see that it's irregular. You might see just sinus tach, you know, PQRS, PQRS. So definitely you could do that. And that's it. Any questions? All right. I'm glad you enjoyed it.